Thank you, Nick. Yes, vaccination is very topical, but then I think we've been saying that for quite a time now, what with one thing and another. And with due respect to my American colleagues, I think Donald Trump hasn't helped, but he certainly has raised the profile along with RFK. So I'm going to talk about some of the basics to do with immunization, and then Helen will talk about the reasons why not as many people as we would like do actually get vaccinated. So first off, I'm going to talk about some terminology. Then I'm just going to list the commonly used vaccines. And I think quite importantly, I'm going to go through contraindications because, as Helen will mention, children with disabilities, people often fight shy of immunizing them quite unjustifiably. And then some specific points about vaccines and Prader-Willi syndrome. So, vaccination these days is taken to mean giving a substance with a view to making someone immune to a condition, usually an infectious disease. The origin of vaccination was actually specific to smallpox vaccination with smallpox virus, though they didn't realize it was a virus at the time. But now it's been broadened to all the vaccines we use. Immunization is slightly different if you're a pedant and is the process of making someone immune. So they could become immune via infection or they could become immune via vaccination. And it's important to remember that not all vaccination results in immunization, by which I mean some people will be given a vaccine and they will still remain susceptible to the disease. In reality, the terms are used interchangeably these days, and it's only pedants such as myself that pick people up on the difference. One can further divide immunization into passive immunization, and this is giving preformed antibodies. So already the person is prepared for an infection. If they come across an infection, the antibodies that they're being given, which will be by injection, will mop up the infection or at least reduce the severity of the disease. Those are used primarily after someone has come in contact with an infection. So if someone has a wound that might have given them tetanus, they will be given tetanus immunoglobulin, or same sort of situation after a needle stick injury, or occasionally for a susceptible person when they've come into contact with measles. Those preparations will, on the whole, have been prepared from human blood with all the risks that that carries, and they are used highly selectively. The one exception to that is an artificial immunoglobulin produced to protect against RSV, that's respiratory syncytial virus infection, a chest infection of young babies. And that is given in the UK to high-risk babies who, if they did catch RSV infection, would be more likely to have a serious illness and perhaps die. It's quite expensive, so is not widely available around the world. And I think I'm right in saying in the US it's given routinely, but I could be wrong. Active immunization, on the other hand, is giving a substance that stimulates the immune system to produce antibodies and memory cells. So the substance could be a part of a germ, could be the whole germ that's been killed, or it might be the live germ that has been toned down, so that while it gives you immunity, it's unlikely to cause the disease. And I say unlikely because for most live vaccines, there is a risk of causing the disease. And in some particularly susceptible people, it may be very severe. And we'll come on to that when I talk about contraindications. How you end up with a killed or component vaccine varies a lot in terms of the technology behind it, from fairly simple things like taking the poison that a germ produces, like diphtheria or tetanus, and treating it chemically and with heat so that it's no longer a poison, it doesn't cause the disease, but the immune system still recognizes it and is prepared when they come across the disease itself. So I'm now going to list very quickly vaccines that are or were in common use around the world. Smallpox being the first vaccine, but now is no longer used. And I say that with some hesitation because I couldn't be absolutely certain that in some particular at-risk groups, it's still not used. And by that, I have in mind not members of the general population, but up until not so long ago, in some armed forces, it was used because it's a potential form of biological warfare. The most modern vaccine is actually still used, but not for smallpox. It's used for monkeypox because the diseases are so similar that being immune to one gives you immune to the other. But as I say, it's not used for smallpox anymore and hasn't been for some time, and is one of the greatest life-saving things that has happened in medicine. Then the next vaccines that came along were diphtheria, whooping cough, and tetanus. And these are part of every country's basic vaccination schedule. It will vary as to how many doses are given and also at the timing of the immunization. The youngest that countries start is 6 weeks, but most start at 2 months. And then they either have a separation of 1 month or 2 months between successive doses, because for these vaccines, you need 3 doses before you become fully immune. And then a whole batch of other things have followed on. BCG for tuberculosis is used in most countries selectively, so just for high-risk infants. Influenza vaccine has been around for quite a long time as well. Measles, mumps, and rubella is the vaccine that tends to get the highest profile and most controversy. And then these others as well. And rotavirus vaccine is one of the most recent vaccines, and this is against a form of diarrhea. Human papillomavirus vaccine is given to prevent, well, it started off being given to prevent cervical cancer, all of which is caused by this virus. But other cancers are also caused by the virus. Cancers of the anogenital areas and also the head and neck, increasingly so. And then the most recent vaccine that has been used on a wide scale is, of course, COVID-19 vaccine. And this uses a number of technologies, some of which are very, very recent. And I can answer questions about that if people wish in our Q&A session. And then respiratory syncytial virus. This is the disease I mentioned earlier on when talking about passive immunity, so giving already formed antibodies to babies. This vaccine is also available to give to the elderly, or as I now term them, the more mature members of the population, but also to pregnant women, because by giving the vaccine to pregnant women, you give antibodies to their fetus, and when the baby is born, they have high levels of antibodies that will protect the baby in the early stages against this disease. And the same principle is applied for giving some of the other vaccines. In most of the industrialized countries, they are taking on giving whooping cough vaccine to pregnant women, protecting in the same way. Flu vaccine, COVID vaccine as well in some countries is given to pregnant women. So we are giving vaccines to an expanding group of people, not just children, but adolescents, pregnant women, and the more mature members of the population. Now, a number of these vaccines, oh, sorry, I should have mentioned chickenpox vaccine. And the colouring here is to indicate that these vaccines in blue are live vaccines. So that's where the germ, for most of them a virus, for BCG a bacteria, has been taken and treated in a way that leaves it still alive, but if you like, has had the stuffing knocked out of it, so it's unlikely to cause the disease. This is a lot of vaccines to be given, and one way of reducing the trauma of this is to give them in combination. So probably the commonest combination around the world is DTaP, that's diphtheria, tetanus, and A stands for acellular, P for pertussis, so that's whooping cough vaccine, which is a much purified form on that was originally used from the late 50s. And sorry, I've just noticed this parenthesis should go up there. So DTaP is often used with inactive polio vaccine, so a 4-in-1, with Haemophilus influenza type B, which, contrary to what the name says, has nothing to do with flu, but it's an important form of meningitis, and epiglottitis, inflammation of the epiglottis that could kill you if it's not treated. So that would be 5-in-1, and then 6-in-1 vaccine, which includes hepatitis B. Different countries have different combinations. In the UK, we use a 6-in-1. In the States, they tend to have lesser numbers of constituents in the vaccines, so more injections. The latest release in the UK, which is behind a lot of countries, is the combination measles, mumps, rubella, and chickenpox. It's been available in some countries for well over 10, if not 20 years. And then meningitis, A, C, W, and Y. The meningococcal germ comes in a number of strains, but A, C, W, Y, and B account for most of the disease around the world. And a MenACY vaccine has been available for many years now. Meningococcal B vaccine is more recent, and up until very recently was a standalone, but now is available. It's licensed in the States to be used in combination with the ACWY to give an ABCWY. The recent outbreak of meningitis that we had in this country was meningococcal B. We reserve this vaccine for infants at the moment. We don't give it to adolescents, and it was adolescents that were affected. And if you want, I can discuss that later. And then there are some vaccines that in many countries are considered travel vaccines, but in a few countries will be part of the routine schedule because the disease is common in those countries. Hepatitis A, part of the routine schedule in the States, but rabies, yellow fever, and Japanese encephalitis, and tick-borne encephalitis, which I haven't put on here, may be part of the routine in some other countries. So a wide variety of vaccines, but a common core, which will include most of these, assuming it can be afforded. And some of the vaccines are very expensive. So what about the adverse effects of vaccines? If anybody says to you vaccines have no adverse effects, I would turn off at that stage. There is nothing we do in life that has no adverse effects. And the decision as to whether or not to have a vaccine is like most of the decisions in life. What are the benefits? What are the adverse effects? The benefits, of course, are protecting both the individual, but to some extent, the population against an infectious disease. And all of those that I listed have the potential to kill in people who are unvaccinated. So on the other side of the coin are the adverse effects. And There will be local reactions to injections, swelling, redness, tenderness, etc. And there will also be, in a proportion of people, systemic reactions, such as fever, being unwell, off their food, perhaps sick. And in a few people, and we're talking about 1 in 1,000 or less, there may be associated febrile convulsions or seizures. And then there will be reactions that are specific to the vaccine. And these are particularly important with live vaccines. For a dead vaccine, I've listed most of the things that one would expect, and they will occur within 24 to 48 hours of the vaccine being given. For a live vaccine, a small dose of the germ is given, and it's only on replication of that small dose that one will see side effects. So for measles, that'll be of the order of 5 to 10 days. And for mumps and rubella, that will be later. And those side effects of a live vaccine may be a toned down version of the disease itself. And it's important, obviously, to warn people about that, because if they are given an injection of a live vaccine, have no reaction, and then 5 to 10 days later they do have a reaction, they may not equate it with the vaccine and may be concerned that their child is unwell for another reason. So contraindications to vaccines are the circumstance where a vaccine shouldn't be given because that balance of harms and benefits is actually unfavourable. There will be more harm than benefit from receiving the vaccine. And to some extent, those are predictable. If someone has had a severe allergic reaction, by which I mean what's technically an anaphylactic reaction, they've had an acute severe obstruction of their airways or hypotension, low blood pressure, they've collapsed, that sort of thing, one would not give them another dose of the vaccine. And that's common sense. You don't do something to someone twice if they've had a terrible reaction the first time round. But it really has to be a very severe reaction. One has to remember that there are a number of things in the vaccine apart from the germ or the derivatives of the germ. And if someone has had a reaction to one of those constituents, even though it's not been in a vaccine previously, they've had it in another medication perhaps, one would not go ahead and give them another dose. And then there may be reasons for postponing a vaccine. If someone is unwell, if they're pregnant and it's not an approved vaccine, and some very other rare instances. In addition to those, if a vaccine is a live vaccine and someone has a poor immune system, either because they were born with it or because of treatment or a disease they've acquired, one should consider withholding the vaccine, because it may be that they would not only get the disease as a result of the vaccine, but in a very severe form. And in these circumstances, when thinking about giving a live vaccine and someone who has a problem with their immune system, then one would usually refer to an expert, because it may be that they could be given the vaccine. Or it may be that the vaccine should be given to their household contacts to stop the disease being introduced into the household. So now moving on to Prader-Willi syndrome, are there any adverse reactions they have different from the general population? There's no literature to suggest they do. One thing that is worth bearing in mind is that some people with Prader-Willi syndrome are more at risk of developing seizures, whether those are with temperature or without. And bearing in mind that vaccines often cause a temperature, it may precipitate a convulsion in someone who has that tendency. But of course, if they were to get the disease, that will often be accompanied by a fever as well. So the balance is still in favour of having the vaccine. I'll point out that febrile convulsions in the general population are quite common in any case. Are there any additional vaccines or doses that one would recommend for children with Prader-Willi? Well, as far as I'm aware, there are no significant problems with the immune system that means they should have particular vaccines in addition to the routine. They do have a number of reasons, though, of course, that makes them more susceptible to respiratory infection. So vaccines like flu and pneumococcal vaccine are even more important to them. And the same applies for anybody with cardiovascular disease and learning disability. COVID and flu vaccines are recommended for those people in various countries. I should say that the recommendations around COVID vaccine are very variable around the world. So one would need to consult local policies on that. In terms of COVID, and forgive me, Tony, but I'm quoting from one of the papers you are an author on, where patients of people with Prader-Willi had a questionnaire to answer about the severity of COVID-19 in their children with Prader-Willi. And in fact, there was no evidence from this survey that they were more at risk of the consequences of COVID. A survey done actually of healthcare records in the States came to a contrary conclusion. And I'll read it. Prader-Willi patients hospitalized with COVID-19 had longer hospital stays, higher charges, increased risks of mechanical ventilation and death. So they concluded that Prader-Willi syndrome should be considered a risk factor for severe COVID-19. And I would agree with that because of the reasons I had mentioned earlier, which makes people with Prader-Willi syndrome more susceptible to respiratory infections. Lastly, we did have someone from Japan, I don't know if you're online, send in some questions about a child who had developed a fever after receiving their first Hib and pneumococcal vaccines at 2 months of age. And they ended up in hospital quite sick, receiving IV fluids, and had blood tests which showed an inflammatory response, which could be due to an infection, could be due to the vaccine. Personally, I would plump for an infection because this is quite unusual post most vaccines, certainly the two mentioned. And the parents were not told whether this was due to the vaccine or an infection. Child, interestingly, had received further vaccinations and had no problems. And the questions were, should one take particular precautions when immunizing someone with Prader-Willi? No, except talking about febrile seizures. If a child with Prader-Willi develops a fever after vaccination, when should families consider seeking medical review? And my advice would be the same as for any child who develops a fever. One should not assume that a child is unwell because of a vaccine. So if the child has a fever and is literally running around feeding well, then can be reassured. But if they are not feeding, listless, etc., I would seek advice. So as you would for any child. And then, are there any vaccines that are thought to cause more frequent or stronger adverse reactions in children with Prader-Willi? I'm not aware of any vaccines that have a differential safety profile, depending upon whether someone has Prader-Willi syndrome. So thank you for listening. And I think we're now going to move on to Helen and have questions at the end.